Good evening and welcome to the final session of Abdomen. Right, as usual, the disclaimer images displayed during this medical training session, they are for educational purpose only. So welcome to grand finale, the final session. Now see, in this session, what we'll do is we'll compile everything, right? So whatsoever we learned, we'll try to implement it, and then we'll see the entire process of delivery of the baby, right? With every details, every stage explained in detail, right? So let's start. Let's see. Yes, good evening. So let's start with the first part. That is the pelvic fascia, right? The pelvic fascia. We divide it into two parts, right? Very easy. One which is parietal, and second that is visceral, right? Name itself is suggesting that visceral, that would be surrounding the pelvic viscera, all the pelvic organs, right? Pelvic organs, and it would be surrounding the pelvic organs, correct? Regarding this parietal, that would be covering the pelvic wall, lateral pelvic wall. So it covers lateral pelvic wall, right? And plus the pelvic floor. This pelvic floor, once again, though we have discussed it in past, but once again we'll see it with all the details of all the muscles, right? In the form of images. Today there'll be lots and lots of images. Regarding this pelvic fascia or this and this parietal part, this is dense and membranous. It has to be dense, right? It has to be dense because it is associated with bony pelvis, right? Pelvic floor, right? That is tough. Lateral pelvic wall, right? That is, so this is like non-expansile, right? This is sort of fixed. While these organs, they do expand. So that's why this is loosely arranged, loosely arranged. So it can expand, right? It can expand. So that's the basic difference between both of them. Now there is some exception, right? That this is usually say non-expansible, but say into the ampulla of rectum, right? If you remember, ampulla of rectum to sacrum, this was ampulla, right? Ampulla was the dilated portion, so we called that thing as the rectosacral ligament, or this was nothing but it was just a sort of fascia, right? And this fascia was also called as the fascia of Walder, right? So in case of say parietal fascia, right? Now we focus on our parietal fascia. We again divide it into two parts, right? As we said that it would be associated with the lateral pelvic wall, all right? Right? Lateral pelvic wall and on the pelvic floor, right? Pelvic fascia of pelvic floor. So lateral pelvic wall, this would be definitely, we said that this is thick, membranous, dense, right? So where exactly it would be attached? One, start with the pubic bone, right? This is pubic bone. In pubic bone, onto the inferior border, right? Now you should be able to visualize, right? Into the inferior border. Then there would be obturator fossa, right? There would be the obturator fossa, correct? So it will cover that. And finally, the Piriformis Muscle, right? So there, which is called as the Piriformis Fascia. Definitely this would be thinner, but this part is thick, right? That is lateral pelvic. And in pelvic floor, so we know it so well, right? There were two layers. This was the superior layer, then there was inferior layer. This inferior layer was also known as anal fascia, correct? And in between fascia, and in between was pelvic diaphragm, right? So that's how they are all arranged. Now let's see over here. So this is pelvic fascia, right? And what it is showing is, that's the parietal layer of pelvic fascia, right? See, it is onto the lateral wall, right? It would be covering fascia over prostate, and as we saw, this obturator internals. So that's how this fascia is really covering it. This is just one very nice and very important concept, right? That how the structures they would be arranged into the pelvic wall, right? Walls of the pelvis, structures in walls of the pelvis. Now, for this, you need to orient yourself properly first. See, this is bony pelvis, right? So it would be like that bony pelvis, and then we are going deeper and deeper. So this is, you can say it like that, this is the outer portion, and this is the deeper portion. This is the deeper portion. How? See, that's the visceral layer of pelvic fascia. So visceral layer has to be near the organs, right? So this is visceral layer. That's the visceral layer. And then this one, the next one is parietal. So this is parietal. The idea is, one, that these internal iliac vessels, they are between visceral and the pelvic layers, right? That is first part. And the second is that the sacral plexus is between, say, those muscles, right? Obturator internals, piriformis, that is these muscles, and the parietal layer. So that is the location, this one. That is the second point. So these are the two things to remember. In other words, vessels, they are between two layers of fascia, and sacral plexus, it is outside. Right. Now see, we analyze all those pelvic muscles so that our picture becomes completely clear, right? Major muscles which we need to discuss, we need to divide it into two parts. One, that piriformis, that very smart muscle, right? From the anterior view, it was looking very small. And very important muscle, that obturator internals. These two were very important. Obturator internals, right? These muscles, they were also, right? If you remember, they were short lateral rotators of hip joint, right? They were short lateral rotators of hip joint. Because in lower limb, we talked about all these muscles along with their original insertion and their movement, so that we really understand that how they actually work, right? So this was what we talked about in lower limb. Over here, we are interested in levator ani, right? Levator ani. This is what is forming the pelvic floor or the pelvic diaphragm, right? That pelvic diaphragm. So, which is dividing the pelvis with perineum, right? Pelvis with perineum. Now this levator ani, right? Levator ani, actually it is made up of three group of muscles, right? There are three group of muscles and we'll see all of them in detail, but just from interior, right? There would be pubis, so pubo, right? There would be ilium, so ilio, and then there would be ischium, so that would be ischio. All of them will be going towards the coccyx, right? So coccygeus. So it would be pubococcygeus, iliococcygeus, and ischiococcygeus. Now, eventually this ischiococcygeus is also sometimes called as just the coccygeus, right? So it is one and the same thing. So pubo, ilio, and ischio. Let's clear this part by watching some images, right? So that it will be crystal clear. Now, before we talk about it, some things which you now should be quite comfortable with. One, regarding the nerve supply. Now see how easy you will find that this levator ani, right? Levator ani, very important muscle, right? So who will be supplying it? One, the branch from S4, right? Branch from S4, and it has got dual supply. Also from the branch from inferior rectal, right? Inferior rectal nerve. Regarding that coccygeus one, right? The coccygeus. This is from the branch from S4 and S5. S4 and S5. Both, in fact, this levator ani, its main function, one, right? Its main function. This would be support. That would be the main function. One is support. And second important function, it maintains continence. And what was continence? Continence is the ability to hold the urine, right? Or the feces. So it helps in bladder and it helps in rectum. This means if anything happens to this levator ani, yes, it would be leading to what is called as the incontinence, right? Incontinence means inability to hold, right? When it is bladder, so it means it is urine. When rectum, so it is feces, right? So that's how this really works. Now let's see all these muscles with complete clarity, right? All these muscles. First thing first, we'll be following a very specific order so that easiest thing first, right? So that there is complete clarity. Let's figure out those ligaments, right? So this is first ligament between sacrum and all this, right? So this is say let's pick this. So here is the sacrum, right? Here is the sacrum and here is the ilium. So what we are talking about is this one, right? Which is going on both the sides. So that is sacroiliac ligament. So that is first. Then we see there is one more, right? Which is going like this. Like this one. This is what we are talking about. So that one would be from sacrum, it is going towards ischial spine. So let's put it over here. And that's our second structure, sacrospinous ligament. So from this point onwards, we'll call this, write this as SS, sacrospinous, and sacroiliac as always SI, right? Okay. Now let's start with the muscles. Our most favorite muscle, right? That is something which we can never miss. We put number 3. That is the psoas major, right? And the brother, younger brother of psoas major, so he'll be rightly said as psoas minor, right? So that's psoas minor. And the business partner of psoas major, because joint operation is for that iliopsoas operations, right? Where they will be going all the way to the distant area onto the femur, right? They'll be going over there for the business. So that business partner, this is iliacus, right? That is iliacus. So far, all good. Now let's talk about this smart small muscle which is looking so irregular, but when we watch from the posterior aspect, it is one of the very important muscle, and that is piriformis, right? We talked about it. Piriformis, short rotator. Now focus on this. Say, can you really appreciate that there is a muscle like this here? There is a muscle over here, and then there is one muscle over here. So if we name it something like, say 1, say 2, and 3. Right now we'll not be worrying much about that who is above, who is below. Just these 3 are the 3 areas what we really want to talk about, right? So let's pick up this first, right? Though we have given it number 2, but doesn't matter. This is, yes, that's the pubis. So from pubis all the way it is going back, right, towards the coccyx. So we need to give it only one possibility, and that is pubococcygeus, right? That is pubococcygeus. Then what about this one? This one, it is going towards ilium, right? So we'll give it iliococcygeus. In fact, ilium, ischium, and pubis, right? So all 3 are involved. And this is the third one, which is going towards the ischium. So we call this ischio-coccygeus. Collectively, all of them, what they are giving us is levator ani, right? That is levator ani. Now this view is absolutely front, right? So if we really want to understand something, we have to really tilt this so that we just try to watch it from the top, right? So that way we'll be getting much better understanding. But at least this much portion is good, right? Regarding rest of the muscles, this is that tensor fascia latae, and this oblique, that is sartorius, correct? Sartorius, this one, right? Something, and obviously this would be the anterior superior iliac spine and the inguinal ligament, etc. Right? You know about that. Okay, let's tilt this. So previously we were watching it like this, right? We were watching it like this, and then now we tilt it so that we are watching from the top. So that way we'll be able to see some more structures. So same style, easy things first, and our intention is to watch for pelvic diaphragm, right? So that would be the entire diaphragm, and this is the diaphragm where we need to understand that it is how the pubo-ilio-ischio-coccygeus, that internal anal sphincter, that perineal body, right? Then deep transverse perineum, all those things, they will be coming into view. Okay, so same style, right? But this time we'll just write psoas brothers, right? Psoas brothers. Oh, sorry. So that is Suva's brothers along with their business partner, iliacus. Sure, that is done. Yes, this muscle, you know it so well. This is piriformis, correct? That is piriformis. The muscle which we are interested in is this. Same way, say it is going like this. So 1, 2, and 3. Right. This one, which is going all the way, so we'll call it pubococcygeus. This is iliococcygeus. And one which is going on the lateral side, that is ischio-coccygeus. Collectively, Leveni. All right. Collectively, Levitereni. Fine. We see some more structures over here. See, first thing which we see is this. So that one is perineal body, right? It is the perineal body. And this ring, that would be internal anal sphincter, right? So this is internal anal sphincter. Here it is. And if I zoom, see there is, change the color, and see this one, right? This one. So that is deep transverse perineae, right? So that is deep transverse perineae. Obviously, that's the inguinal ligament, right? It's the inguinal ligament, who needs no introduction. So these are the structures. Right? By the way, that this one, right? That is from sacrum to ilia, right? Okay. Now in slightly more detail. Here, this one would be just a zoom version. So that is the perineal body, right? This is deep transverse perineae. And you can appreciate this muscle like this. This is internal anal sphincter. This one is pubococcygeus, right? This one will be the iliococcygeus, and this one is ischio-coccygeus, correct? Today is the last day for this abdomen. After that, we'll be starting head and neck. Okay. The muscle which is over here, this is Obturator Internals, right? Obturator Internals. Regarding perineal body, now you know it, so I'm not writing it. And deep transverse perineae, that is the deep transverse perineae. So all good. Okay. Now we have done one extra thing in this. Just for the understanding, right, we removed on one side, we removed pubococcygeus and ischio-coccygeus. This is just to give the understanding these two muscles have been removed. So see, this is pubococcygeus removed, right? And then this one is ischio-coccygeus removed, right, from the opposite side. So that's where we see that, okay, it is this iliococcygeus which has got, this one is iliococcygeus which has got such a big area of coverage. And what we watch in this window, this muscle is gluteus maximus, right? So that's how such an important pelvic floor that is prepared. Okay. With respect to male and female pelvis, now this is like male pelvis, right? Male pelvis. What are the areas or what are the structures which we need to understand? So let's say the first important point is that apparently it would be taller, right? The male pelvis would be taller, thick and heavy. So it would be thick and heavy. Why it has to be taller? Because those iliac crest, right? Because iliac crest, they are high. Iliac crest, they are high. In case of female, you'll appreciate that the entire pelvis is quite wide. So those iliac crests, they go low, right? That is the reason why the basic difference between the male body and the female body. Okay. So this is the first point. The iliac crest is high. This is first important point. Second, the distance between ischium, right? That is the interischial distance. That is less. So that's the second point. The interischial distance. Now theoretically, right, is less. So what difference would it make? Say draw a circle. And in that circle, if these are the 2 points, if these 2 points, they are dragged near to each other, then the final shape would be something like this, right? It would be converging anteriorly because now this distance has been decreased. If this distance is same, so then it would be circular. Well, friends, this is female pelvis, this is male pelvis, right? So in female pelvis, we'll see it is oval, it is rounded, right? It is round, not even oval, it is round. Yeah, it is round. While in case of male, it is heart shaped, right? So that's the reason that it is this distance which is less, right? Another important point, this angle, right? This subpubic angle, it is narrow. So this is our third point, right? Third point, yeah. So third point, subpubic angle, right? It is narrow. At the most about 70 degree. Otherwise, so it is less than that. Normally, right? At the most 70 degrees. In case of female, it would be much higher. That's the third point. Fourth point, the greater sciatic notch, right? The greater sciatic notch. This greater sciatic notch in case of male, it is narrower. Because the pelvis is tall, right? So that notch becomes narrow. The fifth and very important point is, in fact, this is true for any of the bone, but over here, the sacral promontory, right? The most prominent ridge on the sacrum, that is what is called as the sacral promontory. A prominence, write it here, right? Promontory. Prominence on the sacrum. This is very prominent. This is extraordinarily prominent. So that is prominent sacral promontory. Prominence of prominence. Okay. Then this coccyx. This coccyx is, say, in case of female, right, for that baby, right, room has to be created. So in case of female, this coccyx would be pushed back, right? At the same time, it would be flexible, right? While in case of male, nothing like that. So this is coccyx is rigid, fixed, and projected inwards, right? Projected inwards, because there is nothing to worry about increase or decrease of this particular space. And seventh and most important thing, On the basis of this, so many things have been invented into the fashion industry. Right? The acetabula, right, or the acetabulum, right, is one acetabula on both the sides. So in case of male, they are faced less medially, right? They are faced less medially. In case of females, right, they will be spaced wider. In case of male, that space is decreased. So when male walks, right, that walk is straight. Right? Now, when it comes to female, things are completely different. So this was like a male pelvis, right? Let's see same points, right? All these points with respect to a female pelvis. Female pelvis. First thing first, right? What we said that female pelvis is larger. It has to be, right? Broader. It has to be. But if you look at the bones, those bones will be thinner, right? So thin bones. Why really so? Right? Does that mean that these thin bones are weak? Not at all, right? Physiologically, they are strong, but in case of males, because of those muscle power, right? Say, whenever you want to grow your bones, right, you need to apply tensile strength on the bones. So that's why whenever you do exercise, if you really want to make your bones stronger, right, you need to go for those resistance type of exercise, which will actually give a strong pull on the bones, and actually the bone density and the bones will be much stronger, right? Yeah, I remember, right? I got a mail also. Some of you, they were reminding of that physical fitness session. I do remember, right? But definitely we'll go for it. We'll definitely plan. Okay, the second point which we were telling was the shape, but we talked about it. That is that interischial space, right? It is this interischial space that is so important, and it is wide. If it is wide, so then there is no way that this shape would be, say, narrowed. That means it would lead to a round opening, right? So that is the second point. The third one was, yes, that is the wide pubic arch, right? This pubic arch, also called as the subpubic angle, right? So that is wide, maybe 90-degree, right? So pretty wide. So this will be our, say third point, right? That's the third point. What was our fourth point? Our fourth point, greater sciatic notch, right? Okay. So here, the greater sciatic notch, right, that would be wider. That would be wider. So that was the fourth point. The fifth point was sacral promontory, right? So fifth point was sacral promontory. So this is okay. It is less prominent. Very subjective thing, right? Very subjective thing. Say those who are athletes, those female athletes. So yes, in that case, the muscle power would be so good, right, that it would be prominent. So that's okay. But yes, this is the coccyx. It would be short, right, and it would be mobile, right, movable. And due to that, say because of that flexible, and it will be with less curve, so we can write that it is more straight. The idea is just to create more space, right? So it will not be tilted forward, it will be tilted almost, it will be straight, right? So thus creating more space. And finally, the acetabulum, right? Finally, the acetabula on both the sides, right? They are wider, widely spaced, right? They are widely spaced. Now, why I said that so much of fashion industry is associated with it? Because of this widely spaced, this is what gives a typical female gait, right? On those ramps, right? When they walk, even if they don't do it, there is a classical female gait which is like swinging of the hips. But those models, they are given special training, so there they really enhance it, right? One of the another thing that why, right? Just a question that females, they love wearing high heels. Why so? Right? Why so? See, when females, they wear those high heels, right? This would be the position, and this is the heel, right? Now, when this is the position, it actually puts definite stress on the calf muscles, right? Because calf muscles, they will be into that stretched level, but this gives a very sensual curve, right? And it is like these calf muscles, they are vital. Another thing, because of high heels, that center of gravity, that shifts very easily, so that's why hips, they have to work extraordinarily good to maintain the balance, so that will be giving still more sensual swinging gait, right? This is the reason that so many accessories, so many those shoes, everything, right? All those high heels, everything has come into picture. Even the clothes, they are designed like that with all these in mind, right? So anatomy is vital, even from this business industry. Okay, so right, these are the difference between male and female. In bone marrow examination, male is same site examination, because posterior superior iliac is the site for the bone marrow studies. That's right. That's right. Because see, physiologically, so whether is a male or she's a female, right? The bone marrows, they all of them, so they are there. That is a different thing, that in case of say males, right, there would be more bone marrow as compared to females. That is a different thing, but otherwise sites, yes, they will be there, right? They will be same sites, there won't be any much of the difference. Okay, so now the things are easy. This is like what, sacroiliac joint, right? That is sacroiliac joint, because we are about to discuss all those joints. Then let's add few of the ligaments. This first ligament, right, which is absolutely onto the anterior aspect of the spine. This is, from its shape, its name has come, anterior longitudinal ligament. Anterior longitudinal ligament, right? Then this one, let's change the color. This one, right? This is a sort of revision. Right in the beginning, right, we talked about it. So this is between sacrum, that's the sacrum, and this is ilium, right? So we'll call it anterior sacroiliac ligament, right? Anterior sacroiliac ligament. And obviously this one is that synovial membrane, right, which will be forming the joint, right? Synovial membrane. Let's add few more. See, over here, it is going, these are the transverse processes, right? These are the transverse process of lumbar, correct? So from transverse process, right, this is also transverse process, this is also transverse process, and this is ilium, right? That is iliac crest, this is all ilium. So we'll call it ilio, and going towards lumbar, iliolumbar ligament, correct? Then watch for this, going towards sacrum, and this is ischial spine, right? Because we just rotate it and we'll see that, yeah, there is ischial spine. Right now it is hidden just underneath, right? So that is sacro, that sacro spinous ligament, right? That is sacrospinous ligament. And then we have got all those smaller ones, right? They are sacrococcygeal, right? Makes sense, right? See, this is sacrum, this is sacrum, and this one would be the coccyx. So sacrococcygeus. Now, if there are two, right? So one would be anterior, second would be lateral, right? So one anterior and second is lateral. So that's like anterior and lateral sacrococcygeus, right? Sacrococcygeus. And that synovial membrane which was there, now it is covered by articular capsule, right? So that's the articular capsule of hip joint. Okay, let's add, yes, right? Add something more. We just pick up something, all those which are new in this. First thing first, standard, deep, and superficial, right? That's the deep inguinal ring, and this is the superficial inguinal ring. So deep and superficial inguinal rings, right? And over here, all of them, they are going from femur. So now this is going to pubis, so we'll call this pubofemoral, right? Because this area is pubis, so pubofemoral. Then what about the second one which we have marked? This is ilium, right? This is ilium, so we'll call this iliofemoral, because it is going towards femur. So this is iliofemoral, obviously ligament, right? And that one, no doubt about it, this is the obturator membrane, right? So obturator membrane, which covers the obturator foramen. And the easiest one, this is where we have added now the inguinal ligament. Inguinal ligament. Now let's see the joints, right? Which are the important joints? One was between sacrum and lumbar vertebra. So lumbosacral joint, right? That is one. Some less important was that would be between sacrum and coccyx. So sacrococcygeal joint. Well, it is also there, but it is less important. So we'll talk briefly about it. Between sacrum and ilium, right? So sacroiliac. So that's like sacrum. So sacrum is with, say this is lumbosacral, because this is lumbar vertebra, so lumbosacral. Then over here, right, that would be sacroiliac, correct? And then here is the coccyx, right? So that in between would be sacrococcygeal. And finally, all the way in the interior, where the two pubic bones meet, so that one would be the fourth one, and it would be pubic symphysis. Pubic symphysis, right? So if we name them as 1, 2, 3, and 4, so that's 1 sacrococcygeal, that's 2 sacroiliac, this is 3, and this one is 4th, right? So these are the joints which we'll be talking about. Let's talk about all of them individually. The first one, lumbosacral, right? Joint. We'll write only the keywords which will be making the complete sense for this particular joint. Where is it formed? Well, it is between L5 and sacrum, right? That's the first one. This joint, this is thickest, that is its speciality, that this is thickest anteriorly, anteriorly, right? It is thickest. What is the importance? Well, its importance is stability. It gives superb stability, right? Why the stability should be there? Because see, it is giving a strong support. We'll see into the mechanism of pelvis. So it is the sacrum which is wide. On top of it, the entire spine is sitting, right? So when the pressure is going to come, it is going to say get distributed onto both the legs and then to be grounded. So this is stability is because of wide base, that wide sacrum. This is one. And between ilium, right, and that iliolumbar ligament, there was, right, we saw that iliolumbar ligament. That ligament, that strong ligament is giving the good support. So that is strong. This lumbosacral, right, for that we have to watch from the side. It is not straight. In fact, there is an angle which is called as the lumbosacral or sacrovertebral, right? Between sacrum and the vertebra or lumbosacral. It is the same thing. So lumbosacral or between sacrum and vertebra. So sacrovertebral, right? Sacrovertebral. And for that we need to see things from the side. So that's where we find that that's how the sacrum is associated, arranged, right? That's the coccyx. And then those vertebra, right? They will be going like this. So it is over here, the angle is formed, right? That angle is formed. This angle is around 120 degrees, right? So that is what gives the entire curvature. The low back pain, right? Low back pain is classically in this area, right? So very common things, which is called as you'll hear the word sacralization of L5. L5, right? This is L5, lumbar 5. It has become, it has got characteristics of sacrum. So it is like now sacrum, less mobile and everything. So that way it gives pain. Or the reverse, lumbarization, right? Lumbarization of the first part of sacrum. So this is S1, right? Or other pathologies like spina bifida, congenital anomalies, they can give rise to this pain. Also radiologically you will see that sometimes vertebra it slips forward, right? Vertebra slips forward. So this goes like this, right? When it slips forward, that is what is called as the spondylolisthesis. Spondylolisthesis. And pretty painful condition, right? Because over here vertebra it slips forward. When you learn all these things, just remember they can be avoided if your muscles are strong. Then there won't be anything like low back pain. Back pain occurs only when the core muscles are weak. When the core muscles are weak, then those back muscles they are badly affected. Core is what is keeping your body strong and straight, right? And trust me, hardly anything happens when you are young. Though this was a bit surprising that when I started getting so many mails, right? So many emails where in such young age you were having problems of back pain, etc. It is absolutely fine. You can write any of your problem, no worries. But see, if there is any back pain, there can be only one reason. Don't worry about those hi-fi pathologies, etc. No, it cannot occur. If you just sit at one place for more than 3 hours or 4 hours, right? Back pain is inevitable. It would happen. So that's why very soon right? Very soon, actually very soon. I'll be taking that session on the fitness session. Very basic exercises, and those kettlebell or even your dumbbell, just one dumbbell or one kettlebell, that is enough. If it is not there, no worries, even just a towel, that would be enough for those proper stretching, etc. Yes, if you have got some specific instruments, so it would be very beneficial. And that investment is peanuts, and it supports whole of your life, right? So definitely, in fact, I'm planning that today we'll finish abdomen. Before start of head and neck, in between we'll take the fitness session, right? So that definitely will do that. Okay, so this was spondylolisthesis. Uterine prolapse. Why over here? Yeah, it means it can occur, right? Uterine prolapse, but it is because of the problems into the uterine supports. I think you are asking for what exactly is uterine prolapse. When that organ, it starts coming out, right? It loses support and then it comes out. And there are various stages into that. Okay, moving on to this second group of those joints, that is sacrococcygeal joint, right? And there is one more joint, this is intercoccygeal, right? These are all such joints which are not of very tremendous importance. Just we should know about that. Now this is secondary cartilaginous joint, right? This is secondary cartilaginous joint. The important point is that over here there is very thin intervertebral disc. So that is very thin, right? And if there is anything, any fracture like coccyx, etc., so nothing can be done. So it is just rest and it would heal by itself. For the support, yes, it would be sacrococcygeal ligament. Saw that. Now in this sacrococcygeal ligament, it is divided into two parts, say dorsal and ventral, right? Now this is a posterior structure. So again, there is a deep part and there is a superficial part, right? There is a superficial part. So that's how it is arranged. This intercoccygeal joint, it has got one forensic value, right? It has got forensic value, and that is age determination. Its speciality is that between these two, between the coccyx, right? Between the coccyx, they are not fused. Their fusion begins. It begins at the age of 20 years. And by the time it gets complete, so it is completed by 30 years. So it means while age determination, you take the X-ray and you find out that no, they have not fused, but at least partially fused. So one thing is very clear, that age is somewhere between 20 and 30, right? Then there will be other evidences which will be telling that what exactly is the age. So that's what we learn in forensics medicine. That is what exactly is the entire key, which X-rays to take, and just by watching that you add, you subtract few years, and then you come to the conclusion that this is the estimated age. So that is sacrococcygeal joint and the intercoccygeal joint. Moving on to the last one, and this is the sacroiliac joint, right? Quite big joint, sacroiliac joint. Now this is plain synovial joint. And this is plain synovial joint. Now, in sacroiliac joint, though this is a joint, there is very less movement. The reason behind it is that, see, that's the sacrum, right? But the sacrum is not actually like that. The sacrum is like this. And then there are irregularities over here. So these two surfaces, they are quite irregular. So they are not those smooth surfaces so that it can glide. So due to this thing, these irregularity, there is minimal movement, right? There is minimal movement. So this is more or less like a fixed joint. Points to understand in this, that if we really draw it like this, right? This side is, let's say, sacrum, and the opposite side, that is ilium, right? From the ilium side, it would be hyaline cartilage. It would be hyaline cartilage. And on the sacral side, right, it would be fibrocartilage. Fibrocartilage. And sacroiliac joint, so there has to be sacroiliac ligament, right? And same way, it has got dorsal and the ventral part. So dorsal and the ventral part, and this dorsal part, what it covers is all those sacroiliac, those interosseous sacroiliac spaces, then posterior, anterior, right? For all those. So there is a posterior component, there is an anterior component, and it is covers that interosseous area. So that is all covered. Regarding this ventral part, this is nothing but it is just like a thickened capsule. Thickened capsule. Okay. All the other ligaments, they are called as the accessory ligaments. Their function, just they help in support, right? They help in support. So which are those minor ligaments which will, this would be say ilium and lumbar. Ilium and lumbar, iliolumbar, right? Then sacrotuberous, right? Sacrospinous. Why we are calling them accessory? Because see, they are landing on a very small area, ischial spine, right? Sacrotuberous, ischial tuberosity, right? So they are landing over there. Okay. Now for the sacroiliac joint, and you are going to like this. The blood supply, right? The blood supply. Who will be giving the blood supply to them? Well, we saw that internal iliac artery, right? It has got anterior division and the posterior division. We are interested in this posterior division because posterior division was giving three branches, right? Which was iliolumbar, correct? Then second one was lateral sacral, right? Lateral sacral. And third one was that superior gluteal. So this is superior gluteal. So yesterday only we talked about it. All of them, right, they will be happily giving blood supply to this. So will they be going directly? No. They will be just sending the twigs. When we say twigs, that means small branches, right? Twigs means small branches. Right? What about the nerve supply? And this is pretty interesting. Nerve supply, right? It would be from ventral rami, right? See, When we say S1, S2, ventral rami, right? How easy it becomes, ventral rami. But then also from dorsal rami. But when we say dorsal rami, right, only their lateral branch. So lateral branches from dorsal rami and the ventral rami full from S1, S2 gives the supply to nerve supply to sacroiliac joint. So regarding the movements, as we said that these movements, they will not be much, right, at sacroiliac. At SI joint, right, they would be minimal movement. There would be just some rotary movement, but basically there is very less. So instead of movement, you can say that it acts like a shock absorber, right? It is a shock absorber. So you must have seen the shock absorbers, right? When they are like pistons. So when the pressure is applied, right, they will be just pushed slightly and then they will be absorbing the entire impact. Same thing over here, right? Small movement, because there are small movements, so they act as a shock absorber. So because of small movement, just in pregnancy, when the entire pelvis function is to make room for the newcomer, right? So ligaments are weak. So ligaments, they get weak. And when the ligaments, they get weak, at that point, there would be some movements, right? So there would be some increased movements in this joint. Finally, the last one, this is the pubic symphysis, right? Pubic symphysis. Yes, this is also a joint because two bones meet over there, right? So this is just a secondary cartilaginous. So that's the reason this is secondary cartilaginous joint, right? When it is cartilage, so those cartilage, right? So this is one pubis, and on X-rays you will find that they both are separate. In reality, there is a cartilage in between. But for X-ray, right? X-rays they pass through and through it. So that's why this area is not seen on your X-ray. So it looks like there is a space. Actually, there is no space, right? So that is cartilage. In this case, say over there, on one side there was hyaline cartilage, on second side there was fibrocartilage. Here, no confusion. Both surfaces, both these surfaces, that is this and this, right? Both these surfaces, they are having hyaline cartilage. Hyaline cartilage. And who will be supporting them? Well, ligaments, there are two, right? Both are pubic ligament, and one is called as the arcuate pubic ligament. One is the arcuate, it means it is arc-like, and second one is anterior pubic ligament, right? Just for understanding that where exactly that arcuate is. So that's the arcuate ligament. That's the arcuate ligament. Arcuate. And this anteriorly, this one would be the anterior pubic ligament. Right? So arcuate and anterior. Now see, for the mechanism, this is how the pressure gets transmitted. In upper limb, we saw that whenever person falls on an outstretched hand, right? So right from the palm, then it goes to wrist. That's why that wrist fracture, right? Then all the way to elbow. From elbow, it goes to shoulder. Then it goes to clavicle. So that's why the clavicle gets fractured easily. So all those are the weaker areas. So thus, both the clavicles, finally, they will be sending the pressure to the trunk, right? trunk. From trunk, it goes to that lumbar area, right? From lumbar, it goes to, say, sacral. And from sacral, it will be given to those ilium and to lower limb, right? So that's how the entire path goes. All these ligaments, all those ligaments which will be supporting, they will be like, say, sacroiliac, sacrotuberous, right? We talked about it. Sacrospinous, right? And the pubic symphysis ligaments. That is arcuate and the anterior. So that's what they will be. That's how they will be really supporting it. Okay. That's the image which is showing clinical site of tenderness, right? So there would be tenderness. And when the pain is into lumbosacral lesion, right? That is bit high. So here the movements would be restricted. So movements restricted in this case, because it is associated with vertebral column, right? So here there is vertebral column involved. When it is into sacroiliac, right? When the pain is into sacroiliac, that is a lower one. This pain classically appears whenever there is extreme forward bending, right? So here the movements are free, right? Movements are normal, except when there is extreme bending, but otherwise pain persists, right? So, and tenderness means pain on pressure. When you apply pressure, you get the pain. Patient tells that yes, there is pain. Otherwise, if it is just a simple pain, that means person is feeling the pain, right, by himself. Tenderness is when you touch and you find that yes, it is a painful spot. Okay, as promised, we now start with the stages of labor. And this process is also called as the parturition, right? It is parturition. And extremely interesting and so scientific, that is the delivery of a baby, right? So let's see how it really starts. So this is full term, right? That is 37 to 42 weeks, and that's the stage has arrived, right? So about 37 to 42 weeks of gestation, and now the uterine contractions have started. We'll be watching it in more detail, right? This is just highlight uterine contractions, and then starts that final journey of fetus for this world, right? And then there would be delivery, right? There would be two delivery of fetus, and then back to back delivery of placenta, because that placenta is now no more needed, right? So this would be the entire process. Now when we say those uterine contraction, right, let's understand. This will help us in understanding head and neck and even the spine. There are labor pains, right? Labor pains. That is because of those strong contractions. If female tells, no, I don't want to suffer from these labor pains, so then you need to give what's called as the CSE, combined spinal epidural anesthesia. Okay, right. Combined spinal epidural anesthesia. Because in USMLE, they do ask such type of questions. That for the CSE, where exactly your needle would be landing, between which layers, right? So let's see these layers, and these layers will be helping you in understanding so many other things also. So let's start with the inside out. There is spinal cord. Spinal cord is covered with pia mater, arachnoid matter, and the dura mater, right? So this is pia mater. That one is dura mater. Dura means durable. It is tough. So there has to be the toughness outside, right? And this pia mater, right? And if you use this word into Hindi, right, so then it becomes easy that yes, it has to be near, right? So that way it is close to that cord. In between is arachnoid, so no confusion. Now starts that particular space. It is this space which we are interested in. It is this space. And that space is what is called as the epidural space. This is epidural space, right? And then starts all the external structures, right? So this is ligamentum flavum, yellow color, right? This is yellow color. Then there would be interspinous ligament. Interspinous ligament. Sorry. Then there is supraspinous ligament, right? So these are all spinal ligaments, spinous ligament. And after that, there is subcutaneous tissue, and finally the external skin, right? The area of interest, what we need to know is this, that this needle would be landing into epidural space, and that epidural space is between ligamentum flavum and the dura mater. Bus. This you remember. No one is going to ask about interspinous and supraspinous, no. But yes, this thing can definitely be asked. So ligamentum flavum and the dura mater in between space is the epidural space. Now, interestingly, when you are pushing the needle, how do you really know that, okay, now the epidural space has come, right? This is what is called as the, your fingers would know. That is the tactile sensations, right? It is called as the tactile sensation. Not a very big rocket science, but see, when your needle is passing, right, it is passing through thick structures, right? It is passing through those ligaments, and ligamentum flavum as it is going, and suddenly at this point, as it crosses the ligamentum flavum, suddenly there is a feel tuck, right? It goes inside. There is loss of resistance. This is the feel. This is the feel. It is called as the loss of resistance feel, right? So when it happens, yes, now you know that you are into epidural space, right? So just casually, right, I took this. Okay, now back to our main point. So here it is. Now the third trimester, right? Say third trimester is about to get completed. So this is like situation is just before labor, right? Just before labor. See how systematically things start. First, there would be blood or mucus. It will start oozing through cervix, right? Or, right, this is a mild case, or what is called as the water breaking, right? So it is that amniotic sac, right? There is amniotic sac, so that sac ruptures. And when that sac ruptures, so that's what is called as the water breaking. So it means now the process has started, right? And till that point, whatsoever was happening, they were all called as false labor contractions, right? It means false labor contractions means it's not so that female is unnecessarily shouting. No, false labor contractions means false labor contractions, they are like that still there is no onset of say this parturition, right? No, this is false labor contractions, they are like without any show, right? Without any oozing, without any water breaking, they are just there, right? They are without any show, and that's why they are, there is a name, it is called as the Braxton Hicks contraction, right? So these are false labor. Now, if there is oozing, if there is water breaking, this is now called as the true labor contraction. So that is the point when the female is taken to the hospital, right? Because now this is like the process has really started. Now these contractions initially they will be bit mild and gradually they will increase in frequency. So they will come again and again and again, and they will increase in power, right? They will be stronger and stronger. And third thing, they'll also be lasting long. So that means they will be increasing in the duration also. There would be increased duration, right? So from this point onwards, the entire process becomes a completely scientific process in a way that there would be three variables. There would be three variables which will be dealing from this point onwards to make things easy, right? To make this entire complex interactions very easy. 1, 2, 3. So from this point onwards, we'll be talking about this. We'll be talking about that who is generating power, right? So obviously there is only one organ and that is the uterus. So it is the uterine activity which will be generating the power, right? Who is the passenger, right? So obviously it is the fetus, right? That is the passenger. And this passenger is passing through a passage, right? So that is the maternal pelvis. So see, uterus is contracting, that passenger has started its journey, and during that entire passage, it is not a smooth passage, right? There would be so many rotations, etc. So that is what is to be understood. These are the three variables, and these three variables will be giving you complete idea about what actually really happens. So here it is regarding the powers. True uterine contractions, right? So these are true contractions. Initially, they'll be like 3 to 5 contractions, right? And that also in the span of about 10-15 minutes, right? 10 minutes. Then these true contractions, they will be leading to delivery. Now, if this is first pregnancy, right? Again, if it is first pregnancy, so then this thing would last. That's why you must have heard that yes, it is like whole night has passed, right? 12 to 18 hours, right, has passed before the delivery. But as for the subsequent frequent pregnancies, right, subsequent pregnancies, this process becomes much faster, right? It is about 6 hours, 6, 7 hours. So that's, you know, the reason, right? Why for the subsequent pregnancies? Because of those lax ligaments. Those ligaments have become loose, right? So muscles, they have become bit weaker. So it happens like this. Now, if we really want to understand the entire process very properly, we need to know certain terminology, right, with respect to our passenger. Because when you'll be doing ultrasound or when you'll be learning obstetrics, these words will be used straight away. So whenever it comes like fetal macrosomia, right? When it comes like word like fetal macrosomia, that means we are talking about a baby, right, whose birth weight is more than 4.5 kilograms, right? And then there would be like fetal lie, right? Fetal lie. Fetal lie means what? It is about long axis of fetus with respect to long axis of uterus, right? Understand? Say, that's the uterus. That's the uterus. So that's its long axis, right? And what is the long axis of baby, right? So if the baby is, let's say, obliquely placed, like this, right? We'll be talking about this thing in more detail, but if this is the situation, so that's what is called as the lie, right? So it means whenever we'll be talking about fetal lie, that means it would be the long axis of fetus and the uterus, right? Very easy. Then you will be hearing the word like, what is the presentation, right? Fetal presentation. Nothing to do with PowerPoint, right? It is like which fetal part is appearing over the pelvic inlet first. So it's the entire body, but miraculously it is like in normal. That head, it engages and then that head starts moving, right? So it means when the fetal presentation, if it is said that, okay, it is a shoulder presentation, that means it is the shoulder which is coming out first, right? So that is what is like fetal part, which is entering over pelvic inlet, right? Over pelvic inlet, pelvic inlet. So that is fetal presentation. Then there would be position of fetus, right? So what's that? What's that? Position means how the fetus is sitting inside, right? Long axis, right? Fetus could be ulta, right? It could be ulta, but so in that long axis, that remains, it could be same between fetus and uterus, but the position is important. So it is that position of fetus, right? With respect to presentation. With respect to presentation. Now you know it very well that, okay, that's how the fetus is there, right? So what is its position so that which part would appear first? And then, as we called him passenger, so there would be station, right? There would be station. And these stations are like, now you know, those, that is what ischial spine, right? Ischial spine. So you draw a line, and this is station 0, right? This is station 0. Above, they are minus. Below, they are plus. Right? So that is this ischial spine plane, that is what is called as the station. So when it is said that, okay, it is now at zero station, that means now the head has come to that ischial spine, interischial spinal plane. That's where it has reached. Right? So these were the words regarding the passage, right? That is the maternal pelvis. When it will come to maternal pelvis, right? That is the passage. That's where the clinical pelvimetry will come into picture, right? It is the clinical pelvimetry, measuring the important pelvic areas, right? Measurements. So the labor is now divided into 4 parts. So all are like stage 1, stage 2, stage 3, and stage 4. So labor stages, right? 1, 2, 3, 4. So let's see stage 1. So here it is, the stage 1. In this stage 1, now we know that those true contractions, they have started, right? So initial phase, it is what is called as the latent phase. Latent phase, right? This is early, and it may last for 18 to 20 hours, right? 18-20 hours. But what happens in this case? There are irregular contractions. This is important, that there are irregular contractions. Some contractions have come, then for few minutes there is nothing. So variation is heavy, means every, right? This is for every 5 minutes to 30 minutes. So imagine such a big gap, right? And then that contraction would last for say approximately 30 seconds. You are getting it, right? So uh, after 5 minutes, after 10 minutes, sometimes after 30 minutes, right? That contraction is coming, and just for 30 seconds, and then it goes away. In obstetrics, you will be coming across the word effacement. Whenever you will be learning it, this word would be very common. Think it this way, that baby is now entering into the pelvic inlet, and then from there it is trying to now come out. So obviously the cervix, it would be stretched, right? And cervix will become thinner. So that cervix, right, which was like this, right, it would be stretched more and more. It would be stretched more and more. This stretching of the cervix, right, stretching of cervix, this is what is called as the effacement, right? It is effacement. So here the dilatation, cervix is dilated and stretched, right? So this is about, either there is no dilatation or just 0 to 3 centimeters, and this effacement, that is very partial, maybe 0% to about 25%, right? It is just that much. From here, those contractions, from irregular contractions, that's the keyword, now they become regular. They become regular. So now every 3 to 5 minutes, now the contractions have started. Now they are coming more rapidly. At the same time, they are lasting for over a minute, over 1 minute, right? And the most important point, that effacement, which was just 25%, now it has increased to 80%. That means cervix is now pretty stretched, right? At the same time, it has dilated to almost 3 to 6 centimeters, right? Still it is latent phase, but then immediately after that there comes the active phase. Now this active phase is rapid, right? This is active phase, and in this the contractions, they are intense. And see how intense. Now they are coming every 30 seconds. right? Coming rapidly, 30 seconds to 2 minutes. So they are coming more frequently, and at the same time, they last for, watch carefully, 60 to 90 seconds. It means there would be even overlap of two contractions, right? Because one contraction has come, right, and it is lasting for, let's say, 60 seconds. The second one, it started just after 30 seconds only, right? So that second contraction has overlapped the first one. So then that's how it goes. And the most important, effacement, now this is 100%. 100%. Cervix is also now fully dilated, right? Almost to 10 centimeters. So this is like stage 1. And definitely over here in active phase, that amniotic sac ruptures, right? It ruptures. It definitely ruptures in active phase. The moment it ruptures, we have entered into stage 2, right? So here, cervix, it is fully dilated. Amniotic sac ruptured, right? So these are the characteristic of beginning of stage 2. Now this stage is also called as the pushing stage, because this is the stage when the power, when the passenger, and where the passage or the path all are actively involved, right? So first thing, let's be clear that you must have noticed that those who are newborn, right, they're this area, right, that top of the head, right, that is pretty soft. So if this is the skull, you'll find that that portion is pretty soft, so soft that yes, even brain can be palpated, but never try to do that, right? It is not advisable. But this is what is called as the fontanelli. Fontanelli. There is anterior fontanelli, there is posterior fontanelli, right? So they are nothing but those bones, right? Skull in head and neck, we'll see that those skull bones, right? Frontal, parietal, all those bones, they come near each other, and then they, over here in case of fetus, they overlap. They can overlap. So due to this, that passenger's head, right? Passenger's head is, it becomes highly flexible. It becomes highly flexible. After birth, all those fontanelles, they fuse, so then that head becomes strong. But initially, yes, this is quite soft, right? So it can slide over each other. This is first point. The second point, that what would be the attitude of fetal, right? It is called as the fetal attitude. Now this attitude, it has got nothing to do with that how he looks like or how he behaves, but it is like that what exactly would be the position, right, of that fetus. And interestingly, many of the names would come. So normally he is fully flexed. Now those who are doing yoga, they say, okay, take the child pose, right? So immediately, right, head tucked down and then this, and right, that's like child pose. Fine, right? That is normal. Where the chin is on chest, right? So like this. So chin on chest, right? Back is rounded. So back is rounded, right? And those arms and legs, they are flexed, correct? They are flexed. So very decently, right? The fetus has acquired a position so in which minimal space is procuring, and this is the best one. Now, not everyone is like that, right? Not everyone. So something happens, and let's see, this is like a fetal skull, right? Some measurements, and those measurements, they are really interesting. The normal one, first we'll take the normal one. See the occipital protuberance, right? This is occipital protuberance. And in head and neck, say this is frontal, side is parietal, right? And the back side, that is occipital. So this is occipital bone, right? This is frontal bone. So makes sense. Front and parietal, they are like parietal eminence means these are the parietal eminence, right? That's the surroundings, they are the parietal bones. So they are parietal eminence. We have to measure this point. This is suboccipital region, right? That's the occipital, suboccipital under the, and then that's the anterior fontanelle. This one, anterior fontanelle. So this anterior fontanelle and suboccipital part, and let's pick up the line and draw this line, and this one, this line, this is what is called as the sub, or let's write it here. This is called as suboccipital, and that top one, it is called as the bregma. Bregma, right? So this is called as suboccipital bregmatic line, right? And this is the most ideal one. That is where, now you have to visualize, that is when the head is flexed. So when the head is flexed, right? When the head is flexed, so this entire head, right? It will tilt, right? Because this, when he'll be flexing his head, so this line which I have drawn, that will be coming on to the station 0, right? Station 0, because now the head is absolutely flexed. So it is suboccipital bregmatic line that would be now parallel to the pelvic inlet, and that's where we'll start. But for that, head has to be completely flexed, right? So when head is flexed, so when the head is flexed, right, this is the line, right? And that's the body, right? Head is flexed. So this is how it is entering. This is most comfortable, right? So this is what is called as the vertex presentation, and the head is flexed, right? This is normally, it is like that, and this distance would be about 9.5 centimeters. So very fine. This is going towards a normal pregnancy, normal delivery. Okay, let's go for something else. There is another line which is, watch for, occipital protuberance to, we are going towards this point, right? This one, right? That is what is called as the glabella, right? Glabella. So that one, if we call this as number 1, let's put it number 2, right? This would be occipitofrontal, right? So this is occipitofrontal diameter, right? Or the line or the diameter. Now this one, when, if the head is completely flexed, so then this first one, right, that suboccipital bregmatic was there. But if this is like, he'll say, no, why should I look down, right? He keeps his head straight. So that's why this is also called as the military presentation, right? But the trouble is, now the diameter has increased, right? This is 11 centimeters. So this is not going to be easy, right? Though it would be like vertex presentation, but this is the occipitofrontal diameter. Now, things are not ending at it, right? Sometimes the head is completely like this. So that's where it is the third presentation, and that is vertico-mental. This is this place, right, on the mandible, this center one, right? It is called as the mentum. So from here all the way to vertex, that's over here, right? So this is the third one, and that is what is called as the vertico-mental diameter. Now this is 13.5 centimeters. See, so it becomes difficult and difficult, more and more difficult, right? So that's how, say, all these things they occur. Okay, still there are more, but I think for this much it is sufficient. Let's move on to the next part. Now, when we said fetal lie, right? We said, right, this word fetal lie. Longitudinal. So what was fetal lie? Fetal lie was that it was like that long axis, right, between fetus and the uterus, right? Long axis of fetus and long axis of mother. So that is what lie. So if it is longitudinal, it is ideal. Very good, right? It is ideal. So where the baby is also like that and the uterus is also like that, so that is all good. When it is transverse, right? When it is transverse, so either the baby is like this, that's the long axis of baby, this is the long axis of mother, or if it is completely like this, right? Transverse or oblique, so then they are not good. What to do? Well, there are so many things, but we have understood that in lie it could be longitudinal, transverse, or oblique, right? And longitudinal is good, transverse, oblique, not very good. Regarding the fetal presentation, right? We said that fetal presentation. So what was that? Fetal presentation was which part would appear first. So if it is head first, right? If it is head first, so then it is called as the vertex presentation. Very good, right? So in case of vertex presentation, when the head is completely flexed, yes, vertex would be coming first, right? Or even when it is military, still the vertex would come. When the baby is completely ulta, right, which is like the bottom first, so that is what is called as the breech presentation. Or when the lie is oblique, right? Now it is making sense when I say that if the lie is oblique, it means that passenger is at an angle. So when he is at an angle, so instead of head, that shoulder would appear first. So that is what is called as the shoulder first, right? And it occurs when the lie is oblique, right? So here it is the shoulder presentation. So these are all presentations. Vertex is good, breech completely ulta, and shoulder when the lie is oblique, right? See. So now we are starting the entire process, 7-step process. These are all called as the cardinal movement. You will be asked about these cardinal movement. Till this point, whatever you learned, that was for understanding. Because if you have understood that thing well, now these cardinal movements, they'll be like a snap. Instantly you will understand. So this is when Why those movements? Why it is like passenger is not straight away traveling to that path? It is because it is not that easy, right? Everywhere the diameters they are changing. So it is when the passenger is adjusting, right? Very interestingly, passenger is adjusting his position as per passage, right? And starting with first one. This is called as the engagement, right? This is called as the engagement. It means what? That is the passage of widest part of the presenting part, right? The widest part. So over here, this is the biparietal diameter and that's the pelvic inlet, right? Pelvic inlet. So when the widest part of the baby, right, that is crossing this plane of pelvic inlet, right? So widest part entering in pelvic inlet. So that's what is called as the engagement, right? So here it is. If the presentation is cephalic, right? This is very sida sada, right? Presentation is cephalic. So straight away the head is going down. So that's what is called as the cephalic presentation. Head first, right? Cephalic presentation. So see, this is station 0, correct? That's the station 0. So with cephalic presentation, engagement is achieved when station 0 is reached, right? So station, that is at station 0. Now you know what is station 0, right? That interischial line, right? That has been reached. That means at this point of time on vaginal examination, yes, you see that yes, there is emergence of the widest part of the fetus, right? So this is ischial spine plane. Okay. Now, so many things, right, included in one. So this is one before engagement, right? Before engagement. See, there is no dilatation, right? Cervix is closed, right? Cervix is closed. Now, from top there is power, right? That uterus is contracting. Uterus is contracting. So then there is a bony pelvis in front. So head of the baby would automatically be flexed, right? And the descent starts and the downward journey starts. This is where we would call engagement. Engagement was what? When the widest part of the baby, right, that is now going towards that station 0, right? And the descent has started. See this, the cervix has opened. So now that head is pushing, passenger is pushing the passage, and from above there is uterine power, right? So here it is now the downward journey of passenger, right? Okay. The third one. Now see the head has entered, right? Now it would say that we need to take this head out successfully. So it would start rotating. So here there is rotation, right? So initially, see how the movement is occurring, right? First it is fully flexed, then as it goes from that power, as it comes out, it extends, right? Here it is, see, There is complete rotation. Why the complete rotation? Because the idea is that once the head is out, that shoulder is to come out, right? So with that, there is early extension and then there is complete extension. See, the head is now extended. Here it was flexed, right? Here it is extended. And as it is extended, that rotation continues, and this is what is called as the restitution, right? Remember, restitution is what? Restitution is when there is rotation, so that shoulder also comes out. This is like there is rotation, so shoulder comes out, shoulder is out. And when then again, all of these things, that power of that uterus is always helping, right? Then there is anterior shoulder delivery, right? So that one shoulder has come out, and then same way it keeps on rotating, and then the posterior shoulder, that is other shoulder, that also comes out. And then there is expulsion, right? So all those systematically, if we see that these 7 cardinal movements, which movements they were there, right? 1, 2, 3, 4, 5, 6, 7. The first one was engagement, right? Engagement. And in that we'll remember the word station 0, correct? That is when the interischial spine plane, that is what we will be considering. Then because of that power, the descent starts. It starts, and because of that pressure, that baby's head is against that bony pelvis, so automatically, right, he becomes decent and he flexes his head. So head is flexed. Then when the head is out, there starts the internal rotation, right? There starts the internal rotation, right? So in this case, this is 45-degree rotation. And how do we know that this is 45? Because we are on at this point of time station plus 4. That means 4 centimeters from the interischial spine plane, right? At station 4. So there is internal rotation. And then as this passenger reaches station 5, right? His head is extended. So now head extended, right? So smart, right? So this is the 5th one. This is extension. Now, so previously there was internal rotation. Now this is the point when the shoulder is to come out. So head is extended. So previously flexion, right? Internal rotation, head extended, and then once again external rotation. So there starts the external rotation. And this external rotation is for those shoulders. And that is what is called as the restitution. Restitution. And this is for shoulder. This is for shoulder, right? For the ease of passage of that shoulder. And once this shoulder is out, right? Finally, it is what is called as the expulsion. Expulsion. Right? So in this expulsion, the anterior shoulder, right, that goes out. As this anterior shoulder, it passes symphysis pubis, right? Pubic symphysis. As it passes pubic symphysis, that posterior shoulder appears. And then once posterior shoulder is out, then the rest of the body is out, right? So these are what is called as the 7 cardinal movements. The most difficult portion is complete, right? But so interestingly, now comes the stage 3. right? That is just, say, after the baby is delivered, right? Now baby is delivered. Uterus contracts very strongly, right? Uterus contracts. And this is pretty strong. Reason? Uterus would say, now let this placenta go. So that placenta separates, right, from the uterine wall, and this is removed. So that is the stage 3, because nothing is to be left out, because there is no point in that, right? And finally the stage 4, and this is after several hours, that uterus, it starts going back to its original state, original size, right? So back to normal size. And because of that blood loss, so body is just adapting to that blood loss, right? So that's why rest, nutrition, and that is what is needed. So that's it, right? So that's the happy baby, right? So this is for today, and thank you so much for the final time for this abdomen, right? And next we'll be starting with head and neck very soon. Before that, definitely we'll be going for that fitness session. But trust me, it was a pleasure talking to all of you, right? Thank you so much, and we all meet very soon. And in case of any query, do let me know. You can mail me, and I'm saving this file into our shared folder. Thank you, and bye bye. Good night.